the non-conservative treatment of invasive cervical cancer treatment. Next slide, please. The data from Santé Publique France indicates that per year, the incidence was 3,000 and mortality 1,000, and the overall survival at 5 years is 63%. But in my point of view, the most important thing is that there is a break in the slope of the decrease in incidence and mortality in France. As you can see, we observe a decrease in the overall survival at 5 years of 6%. Most of these cancers are due to cancer in young and not vaccinated women, despite a good screening. So probably there is a problem with molecular biology, and we have no many informations about this, about the molecular biology of cervical cancer. And this is a pity, because probably the treatments have to progress in this direction. Next slide, please. All our files are discussed in multidisciplinary teams meetings. So 2 key points are discussed: the tumor size measured by MRI and nodal or lymphovascular status, which is appreciated by a PET scanner or lymphadenectomy. And the decisions are around radiotherapy, brachytherapy, chemo or immunotherapy, and of course, surgery. Next slide. For the earliest stage, stage 1A1, the most important thing is the lymphovascular involvement. In case of lymphovascular involvement, we recommend a pelvic lymphadenectomy or a sentinel node during a trial. If the nodes are negative, we recommend actually a radical hysterectomy type B, and we discuss this point after. Of course, in young women, ovarian preservation can be proposed. If the lymphovascular involvement is negative, the risk of positive node is very low, so we consider only the margins. If the margins are free or more than 5 millimeters, we can consider a strict follow-up using virologic testing. In case of margin positive, it's recommended to perform a radical hysterectomy type A. Next slide. In case of stage 1A2, with a risk of positive node about 7%, it's recommended to perform, before the treatment, a pelvic lymphadenectomy and possibly a sentinel node with a frozen section during the operations. If the nodes are negative, we recommend radical hysterectomy type B, and type A has an option with ovarian preservation. Next slide. In stage 1B1, so less than 2 centimeters, we perform, before to decide the treatment, pelvic lymphadenectomy or sentinel node with intraoperative section. And if the nodes are negative, radical hysterectomy type B. As an option in especially young women, and Patrice Malvé will discuss this point, or in case of aggressive lesions with lymphovascular involvement, we recommend, before to decide the treatment, the realization of PET scanner or lymphadenectomy or sentinel node. And only if the nodes are negative, we can perform a radical hysterectomy type B. Next slide. In stage 1B2, many teams perform, before the treatment, an evaluation of the nodes. If the nodes are negative, brachytherapy is recommended, and after 6 weeks after, we perform radical hysterectomy type B as an option for patients, from fragile patients. We recommend only after the brachytherapy and external radiotherapy. Next slide. As many teams in all the world, in more advanced stages, we perform a PET scanner and laparoscopic lymphadenectomy if the PET scanner is negative. As an option, some teams perform a pelvic lymphadenectomy, particularly in case of massive involvement of the node with nodes more than 2 centimeters. And after, we do a concomitant radiochemotherapy with brachytherapy. Some teams, in case of unresectable nodes, put clips on the nodes and do a boost on this node with radiotherapy. And actually, it's a big discussion about adjuvant chemotherapy, in particular cases in very young women with aggressive tumors. And after, we perform a strict follow-up with MRI and PET scanner at 3 months, because the recurrences are very, very frequent and with a very, very poor prognosis. In case of major risk of fistula, or if a fistula exists between rectum and bladder, we perform usually an exenteration, pelvic exenteration. Next slide. In case of recurrence, it depends of MRI and PET scanner, of course, and if the patient have not received radiotherapy, we do radiotherapy. It's the most frequent option in this case. If the patients have received radiotherapy, we cannot do radiotherapy, so we do pelvic exenteration. And our best results are in case of a delay between the end of the first treatment and the recurrence more than 6 months, and in case, of course, of central pelvic recurrence. Actually, there is a big discussion in the systemic treatment with chemotherapy on the more frequently with anti-PD-1 molecules, if the tumor is acceptable to this treatment. Next slide. There is 2 points under discussion, actually. One of them is the type of radical hysterectomy, and in France, we use commonly the Kerlo-Morrow classifications, which is distinguishing type A, B, C, D, and in case of favorable prognosis factor has tumor less than 2 centimeters, stromal evasion limited to less than 10 millimeters, node and negative and lymphovascular space not involved, and young people, we do only radical hysterectomy type A, which is easier to do and with less morbidity for the patient. Next slide, please. The second point is, of course, the minimal invasive surgery, which is actually very, very discussed, because we have many trials, and LAC trial as LAC trial on soccer study, and a French recommendation from the group of gyneco-surgeons is to inform the patients of the results of the trials. And many patients are frightened by the results and prefer, in my region, laparotomy than laparoscopy after the information. The recommendation is also no uterine manipulator, perform a vaginal colpotomy if you use laparoscopy, of course, and use brachytherapy for 1B2 tumors, and this surgery has to be reserved to trained operators. Next slide. 2 slides about cervical cancer and pregnancy. If the patient wants to continue the pregnancy before 24 weeks, in case of earlier stage, conization is efficient. In case of more advanced stage, lymphadenectomy and possibly neoadjuvant chemotherapy after 12 weeks of pregnancy. If nodes are positive, discussion is about therapeutic interruption of the pregnancy. In more advanced stages, lymphadenectomy is recommended with chemotherapy neoadjuvant. Next slide. After 24 weeks, if the patient wants to continue the pregnancy after clear information, in earliest stage, 1A and 1B1, we wait for fetal maturity, and then we perform the treatment as the recommendations we have seen before. In more advanced stages, for 1B2 or more, we do neoadjuvant chemotherapy. Next slide. Thank you for your attention. This is a view from my regions with the land and the sea. Thank you.